Hi, Dr. Powden. This will be me talking about my CAM/Integrative Health Implementation Part 2. So I chose to utilize cupping as my integrative technique, and I did this for actually a couple of reasons. One is that it was always something that I found to be fascinating. Of course, everyone saw the Olympics, so it's something I can finally say like, oh, yep, I've used it. But mostly because in my undergraduate setting, I did not have access to this technique, and it was very frowned upon because it was alternative medicine and or complementary medicine, and the athletic trainers I worked for as an undergrad wasn't very supportive of it. So it was kind of seen as like a witch trick, whatever you want to call it, a hoax, and so it was always looked down on. And then when I got here, it was something that everyone used, everyone knew how to use, and all the athletes praised it. And it was such a crazy thing to see how the drastic change it was. So I decided to utilize this for those two main reasons, is that it was something new to me. It's something I've never had a chance to learn, and it was something that I've been able to see the benefits of in my own practice, in my own setting. And now after this project, I've been able to use it on my own patients. So those are the two main reasons why I chose to choose cupping. Now I did a little bit of research, and it is shown to increase range of motion and and decrease pain, but a lot of the research I've seen is on low back pain. But with the amount of improvements I see in patients of my setting, literature does, it does play a huge part in it, but when you look at patient values and clinician expertise, it's really hard to dispute. But again, I have to remember that it's not going to work for every patient, and that's definitely one thing I'm going to learn from this integrative project, which we will touch on in a second. um, so when I was taught cupping, I learned from someone that was experienced in it, and she had it in her master's program before she came here to the DAT. She had an entire certification class on it. So she taught me just a few of these techniques. The single static was one. You just kind of place it. Um, well, you don't ever, that's one of the things we're going to touch on, but like you never want to put it right on the spot that, like such as a trigger point. You want to always start like at a different area and then glide towards it. So that's a single static, and then the single glide was using one cup and gliding along an area to promote blood flow in an area and then elongation. Those are the two main ones I learned. She also taught me the high velocity pop, the anchored glides, and linear diagonal lines, but she did more of reference. It's not something that I feel comfortable doing, especially since I'm not certified. But it's something that I do look forward to learning about in the future, especially if I do get certified. So a high velocity pop is using two cups that are next to each other, elongating the muscle, and then when you get to the point of most restriction, you pop them up. Anchor glides, it says exactly what it sounds like. You put one down and you glide a second one in the direction of the muscle. And then linear diagonal lines, which is when we look at such as the Sarabe effect or cross pelvic syndrome, where it's going along one fascial line and it can cross into the lower and upper extremities. Um, when I was taught, they emphasized 30 to 90 seconds minimum time, and a lot of the clinicians here say about 3 minutes. 3 minutes of either sitting there and then using range of motion, which can be used for, or sitting there for the 3 minutes, but any more than that can be harmful, and any less than that, you're not going to see the benefits. Like I said earlier, never want to start directly over the trigger, and oh, excuse me, my computer shut down for a second. And then can be utilized with active or passive range of motion to promote elongation and gliding of the muscle. So that's one thing that I definitely used on this patient that I chose to incorporate it on. And one thing that was made known to me is to make sure to perform a light effleurage after to kind of just flush everything out. So when I used this, I decided to use it on one of my patients because it was a new technique. It was a Division I athlete. She was a female of age 20. She had hamstring tightness, and upon evaluation, I mean, it was clear that it was in a chronic stage. She had a history of straining it, but That was last year before I got here, and then she said that it had been hurting her and tight all throughout the summer. And she said last year she had done a lot of cupping, and it was what really helped her the most. So at first I was very hesitant on it, and I started with stretching and foam rolling every day for a week, and that did not do anything. She felt that she was really, really discouraged, and she felt that it wasn't helping at all, and she was still having some shooting pain down her leg. And so then I turned to alternate treatment, which I just decided to do was cupping. So there's a lot of information on this page. The next slide will kind of make it a little bit easier to see, but basically I learned how to do cupping the 29th of September, and my first cupping session was the next day. And then I took her active range of motion. I chose active range of motion because she's very apprehensive to passive range of motion. Whenever I would try and put her into full extension of the knee, she would be guarding. She had a very hard time relaxing. So I chose to implement active range of motion because it's something that the patient was more comfortable with. And this is something that differed from my part one, was that I thought I was going to do passive range of motion, and I decided to do active just because of the patient preference. And I was consistent with it, so I didn't really see any reason why it couldn't give me the same information. So it was 60 on her good leg and 40 degrees on her bad leg. And then after that, I didn't take it immediately. The first day I ended up taking it a couple days later, and then the rest of that week, she said she was feeling better. She had a score of 1, and then she had a score of 3, so it got a little better throughout the week. So then I decided to implement the cupping again the next day, or excuse me, the next couple days later, so the next week. And the score before was 0, and she said there was no change to when she first felt, the way she first felt, and then her score afterwards was a 3. So she definitely felt a lot better after the cupping, which was a positive sign. And then I took the grok again a couple of days later, and it was back to a score of 1, so a little bit changed, but not much. And then did a third cupping session on the 19th, which so about 9 days after the second cupping session, and the scores were even lower. So a 0 before and a 1 after. So 0 being no change and 1 being just a little bit. And then I took the fourth grok, the global rating change scale, patient questionnaire. I took that a couple days after the third cupping session, and it was a score of 0, meaning no change. And I chose to incorporate the grok because it was going to show me the change, and I wanted to see, instead of function over time, I wanted to see if the cupping was helping, so that's why I utilized that. And it was quick, and I felt that I could get the most compliance, excuse me. And then finally, I reassessed her on the 24th, so about 3.5 weeks after the initial reassessment, and I decided to go for a month instead of 2 weeks. It was a little less than a month because we were getting into full 2-hour practices every day, and it was a lot, very taxing with her soreness, and so we did not implement cupping as often as I'd hoped. But it turned out to be okay, because when I re-examined her active range of motion for both legs, I mean, she'd barely made any progress, 6 degrees. And I reevaluated her because I was really unsatisfied with the improvements we've been making in 3 weeks. And turns out her actual injury was tightness secondary to her glute muscles were not firing, so her hamstrings were overused and it was spasming as opposed to just tightness. So we stopped the cupping, left the hamstring alone, and we've been focusing on the butt ever since. And so that turned out to be an interesting twist. So if you see here, I did a little calendar. I started on the 29th, ended on the 24th. Cupping was the 30th, the 10th, and 19th. I was unable to do it the first week of October because I just started full-time practicing since season starts October 1st, so she was really sore. Waited to do it until the following week since she was less sore. And then the purple check marks was when I took the grok. So I took it twice a week and until I stopped on the 24th. Overall impression is I really enjoyed using this tool. I felt it was very helpful and I learned a lot. Now this athlete, although the injury wasn't conducive, the treatment wasn't going to help this particular injury because it was the wrong source, or I had the wrong idea of what the actual injury was. So it didn't necessarily help this patient in particular, but I've used it on a couple other patients, and one in particular was shoulder impingement due to tightness, and she really, really benefited from the cupping because her actual injury was tightness, and that was the cause of her pain. So I felt that was very, very good for her. She loves it. We do it twice a week, and I take her grok, and it works out really, really nicely. But I chose to just focus on this particular patient for the implementation plan. So for this particular patient, again, her feedback was that she felt it stopped working and it wasn't working as good as it felt last semester, which makes perfect sense because obviously the injury was different from last semester. So she didn't have as much improvement there, but she liked cupping. She felt better afterwards because it did bring her relief to her hamstring, but it just went back to normal, and that was very discouraging to her. But I think overall, she would not be hesitant to try cupping again on a different injury if that is what the injury warranted. Um, but I definitely will look forward to implementing this better, especially if I plan on getting my certification in the future, because I have seen the benefits, and especially with different patients, not necessarily this patient, but in my other patients. And if anything, this has taught me a lot about my evaluation process and going over what I need to work on in my evaluation, so actually finding out the cause of an injury. So, but definitely we'll be looking forward to implementing this at a later time and only improving for myself and my patients. Thanks, Dr. Excuse me. Thanks, Dr. Bowden.